Okay, welcome everyone to our first ever Pasifika Grand Rounds. We are um, uh, putting on a medical lecture series um, to help improve the care of all people, but focus on the Native Hawaiian and Pacific Islanders. And so this is co-sponsored by the Healing Association of Pacific Islander Doctors, the Mapu Maia Clinic, and Pasifika by Design. And uh, we will talk later how you can engage with the series to suggest different topics you want to hear throughout the year. And for the most part, we'll go over sort of when you can hear it or when the lecture series will be available. And so we, hi Trina, uh, we have done this specific topic in celebration of a clinic that's opening. The Mapumaya Clinic is scheduled to open tomorrow, which is a huge undertaking and very historic in regards to the delivery of Pacific Islander care in the U.S. And so, just because it's a momentous occasion, I thought I would bring Tepa Baina, who's crucial in coordinating the clinic and the clinic opening, to say a few words about the clinic. Congratulations. You want to say a couple words, Tepa?
Sure. Thank you, Dr. Samuel, for that wonderful introduction. Hello, everyone. My name is Tepa Vaina. I use she, her pronouns. I am a Fa'afafine born and raised out of American Samoa from the village of Aluau. And I currently serve as the health clinic director for Utopia, Washington. And our health clinic is named Mapu Maia. And just a little bit of context on that, Mapu Maia is a phrase that you offer to someone in Samoan when they've had a very long, rough journey. And so if you see someone that's had that type of journey, you say to them, Mapu Maia e Falene, which basically means you may rest in this house, you may find relief in this house and comfort. And that really is the sentiment that we are trying to convey through the opening of Mapu Maia. When it comes to gender affirming care, it is not a secret how difficult it is to find gender affirming resources, let alone find a place that offer those resources, but also feel like we are seen and respected while we're getting those resources. And so when we realized that it was difficult to find that elsewhere, we decided to take up the mantle and just try to build the clinic ourselves, utilizing our own lived experiences to inform how we want this space to come through to the community. And we're very happy today that we have partnered up with a wonderful physician here in Washington State. His name is Dr. Malik Fumono, who is going to be our medical director, which is a very, I guess, very important part of having any clinic is to make sure that you have a medical director that oversees all of the functions and services that are going to be provided out of Mapumaya.
Thank you, Tepa. And so, with that, one of the topics that the Mapumaya Clinic identified as a need for their clinic, but also for anywhere that provides service to Pacific Island communities, is gender affirming care. And so, I decided we would speak to this as a from a provider's perspective, Pacifica provider's perspective. And so my credentials to speak on the matter is that I'm a board certified endocrinologist. So endocrinology is the field that generally gender affirming care is given to. And so this is within the wheelhouse of my subspecialty. Um, and so for that, let's go on to our next slide. I just wanted to acknowledge um, the original stewards of the land that I'm presenting from. I am in Southern California, namely near the Los Angeles area, where the Tongva tribes had long were stewarding the land before any other groups came here. Um, you don't hear about them very much because they had to deal with a history of forced relocation, enslavement, and a lot of sickness due to immigrants that moved to this area. Um, I also wanted to acknowledge our connection as the daughters and sons of Moana. That the ocean that binds us together, should motivate us to work together for a better day for all our people. Next slide. I just want to make sure you know, this is a medical talk, but even though this is a medical talk, the content of this talk and all Pacifico Grand Round talks are provided for informational purposes only, and this does not intended to substitute professional medical advice, diagnosis, or treatment, and should not be used in such a manner. Next slide, objectives. So, what we want to get done today is we want to review options in regards to the care of Pacific Islanders in a gender affirming space. We want to describe the hormonal management, the standard of care for patients transitioning from male to female. We do plan to talk about the female to male transition, but also gender affirming care with children that are non cis in future talks, but we only have 25 to 30 minutes, so we've decided to break those up. We're going to talk about the medications involved in transition and also identify resources available for reference. Next slide. So real quick, we talked about the Pacifica Grand Rounds being a joint educational project. We'll talk more about our joint sponsorship later on in the talk. And know that these lectures are aimed at improving the delivery of care to Native Hawaiian Pacific Islanders through education. And we mainly want to work towards deconstructing some of the systemic inequities that lead to disenfranchisement in the healthcare system for Native Hawaiian Pacific Islanders. Right, next slide. So our primary goal, as we said, is to provide safe space. It fits well with the Mapu Maia translation and provide quality care for all NHPI through sufficient gender affirming care. So, why is it important to make the space welcoming? Well, there's evidence that we have that shows that this environment where we deliver care can influence the healing process. It can have direct impact on the outcomes of patients, such as reducing their anxiety and their stress. It can shorten recovery periods following surgery. It can also decrease behaviors that can lead to worse illness or recurrence of disease by creating a supportive, stable environment for patients. So let's start with like providing gender affirming spaces. In the environment itself, it starts with staff. You know, physical space is important, but everything starts with staff. And if you want to make the space affirming, you have to provide the training that allows the staff to deliver gender affirming care. There are many resources when it comes to this, and so you should utilize them. Signage is important. When you have a place that sort of says it in clear lettering that you provide gender affirming care and that that's the goal of your clinic, people tend to want to go there, right? Another way you can provide affirmation is through gender neutral bathrooms. Um, uh, I was reading through social media, and one of the comments that someone made regarding, you know, the the bathroom issue was to let them use the handicap bathrooms, which can tell you sort of where the deep-seated hate comes for people seeking gender affirming care, and so diffusing that type of mentality by providing gender neutral bathrooms goes a long way in telling people they're safe. Another thing that helps promote gender affirming spaces is to make sure that the clinic is a safe place to learn. You know, not everyone is that familiar with how to be gender affirming, um, and so we have to make sure that uh, that questions are somewhat welcome. but that you hold each other accountable to uh, adhere to the most respectful way to deliver care for all of us. Next slide. So, language. Providing gender affirming spaces, including language. It's really good to make sure that all staff are trained on an agreed approach. One of the things that kind of doesn't give people the greatest confidence is when you have different staff use different ways to approach language. And that inconsistency just means that your quality of care is dependent on a person, not your entire clinic. So, one of the things that should go into training is how to address patients by using friendlier statements such as what pronouns do you use? You want to avoid statements such as identifies as trans male, rather so and so is a trans male, because the identifies as a trans male sounds more like the patient's preference. Um, and so we want to avoid that type of subjective language. Um, Also, you want to be familiar with the term dead name. Dead name means birth name of someone who has changed their name as part of their social transition, and should be given the weight that it is just another term. Um, and then electronic records should have a reflection of patients' pronouns, so that they don't keep getting asked the same questions over and over again. So when I see a patient for the first time that's seeking care, it's really important that I use that visit to help sort of prepare a lot of things regarding the patient's treatment. Um, I like to think of it as teoleba. So teoleba is a Samoan saying that prepares the field for business or working together. And so the main thing that you have to do to uh, to get ready is to establish trust, um, and you do that through using gender affirming language, also have a gender affirming approach by staff, so that by the time they reach the provider, they already should feel safe. Because what does safety do? Safe allows you to obtain a more accurate medical history. People are more likely to answer honestly when it comes to questions like gender dysphoria. They'll also be more clear as to what types of goals they have in regards to their treatment. Um, you also want to gather their family history, chronic diseases as such, their social history, which includes any substance use in the past, alcohol and tobacco use, their employment history. All of these things are very important in sort of getting a very comprehensive view of your patient. Um, you want to screen for eating disorders. You want to look at some social determinants like transportation, um, you know, geography, where they're coming from, what type of cultural obstacles that they may have to deal with in obtaining their care. You also want to look at domestic violence and sexual history, as a lot of these have, in previous survey that we've done, have huge implications in a patient's treatment. And then immunizations as well, such as Hep A, Hep B, um, and the like. Next slide. So we should know that there's three types of transition: social, medical, and legal. And that's why these cares should not really be isolated to just the exam room. You should put together a multidisciplinary team when you're treating patients that are transitioning, because these transition plans need to be tailored to each individual patient. And how do these work together? Well, if you have somebody that's in like chaos in regards to their social transition, there are medical transitions that probably are not appropriate at that time. You also want to make sure that their legal status is being worked on, because sometimes that has a huge implication on how what your treatment options are. Next slide. And so you can see these are the different groups that deal with the different transitions. You'll need like social workers, psychologists, therapists, counselors for their social transition. So social transition is transitioning in your um, families, at work, things of that nature. Your medical transition is more of your biological transition, and so that's more laid upon your physicians and nurse practitioners and the like. And then legal transitions are usually done with the guidance of lawyers, but there are also like a lot of community advocates. The nice thing about the Mapu Maya Clinic is it's attached to Utopia, Washington, that has a lot of these resources made available to individuals that need it. Next slide. So transgender females. So let's get into the bulk of it. Next slide. So the male and female transition, you want to really make sure what the roles are. You know what patients are expected to do. You know what we expect from them, and then what is expected of doctors. You know, uh, that way there's less frustration when outcomes are not really optimal. Okay, and but it's easier to find solutions when you know who's doing what. You also want to manage expectations. What are possible with treatment options and what's not possible with treatment options is always something that you should have before any treatment. You want to discuss fertility because sometimes this becomes problematic when you're in the midst of hormone transition. So you need to have those discussions up front. And then, has the gender dysmorphia been confirmed by a licensed therapist? And do they support hormonal therapy? And this is really, really important. You want to make sure that you're not just looking at this from one lens, that you're looking at the comprehensive person when you're trying to come up with treatment options. Next slide. So with transgender females, the goal is usually feminization and suppression of secondary masculine sex characteristics. And so that's what the hormone therapy is aimed at. We do that using estrogen class or estrogen. Um, and generally, we have two steps to hormonal therapy. There's estrogen and anti-androgen. Um, and then we also consider progesterone, although that's less studied than estrogen and anti-androgen therapy. Next slide. MTF initial labs. So comprehensive metabolic panel. That's something that we order on everyone because you get a look at their kidney function, liver function, and any electrolyte abnormalities. I always look at hemoglobin A1C because I'm a diabetes specialist. Um, but it also tells you like how healthy or unhealthy your patient is metabolically. We get fasting lipids, which has your cholesterol, prolactin, which is a pituitary hormone that has a lot of play when you're dealing with hormone transition, hematocrit, because sometimes when we do transition, patients become anemic. And then your total testosterone, FSH, LH, and estradiol are needed for baseline labs because you're going to be adjusting those hormones. Um, there are different types of hormone dosing. Uh, if you choose to do oral, you're generally trying to start with 1 to 2 milligrams per day. Um, and then the maintenance dose is usually about 2 to 8 milligrams a day. Um, the dose is greater than that, which sometimes happens when we're dealing with some of our larger patients. We generally try to split that up to take it twice a day. Uh, there's subcutaneous estrogen, which are injections. Generally, we give about 2 milligrams a week to start, and the maintenance range is about 2 to 7 milligrams per week. We generally do about 4 milligrams a week. That's about the usual dose. Um, and then there's the patch, uh, the transdermal estradiol. I generally start with like 50 micrograms. We do it about 1 to 2 times a week, depending on the size of the person. I generally start once a week just to get the patient used to the estrogen. And then maintenance range is about 100 to 400 micrograms applied 1 to 2 times per week. It generally depends on what the the instructions are for the patch, and that's usually the maintenance dose. I'm sorry, that's usually what we give. Um, Next slide. So progesterone is another hormone that's made by the ovaries. The ovaries makes estrogen and progesterone. It's not as well studied in transition, and so there are some studies that showed that you can get improved mood, and enhances sex drive. It can enhance breast development. But in other studies, it shows that sometimes the mood worsens. And we haven't been able to tell whether or not the breast development may be related to weight gain, because you can get some weight gain with progesterone. And so the dosing questions are not optimal because it's not well studied. So hopefully in the future we'll have better guidelines regarding progesterone as the research improves. And because you're using both hormones, you'll be cycling, which can cause premenstrual syndrome symptoms. Next slide. Okay. So our monitoring when people are on estrogen, um, or estradiol, is we check 3 months, 6 months, yearly, and then when when needed. I generally never let patients go more than they have to be seen at least yearly when they're on these hormones. Um, we check an estradiol level 4 to 6 weeks after dose changes to make sure we're not excessively high. Um, when we do shots, we check trough levels. So we generally do it. So a trough is the lowest point, and we usually do it the day before the next injection. And we also do another level in between. So if you do a shot once a week, you'll do a trough the day before your next dose, and you'll do another level 3 to 4 days in, which is mid-cycle level. Um, and then if side effects occur, you can check peak levels 2 days after the injection to make sure it's not excessively high. Next slide. So our monitoring labs are not, they're pretty simple. So we measure a testosterone level to ensure that it's lower. Um, I usually check when starting therapy at 3 months, then 6 months, and then 12 months, and then as needed. Um, Once we get to a steady state, like I said, I usually check every 6 months, and then if a patient's extremely uh, stable, we'll go to 12 months. Um, um, Prolactin, fasting lipids, hematocrit, hemoglobin A1Cs, and um, uh, liver function tests. These all should be checked in the beginning. You usually don't check it unless there's something abnormal, um, and that you're monitoring. I usually get fasting lipids and A1C and liver function tests in Native Hawaiian and Pacific Island patients because metabolic syndrome, such as diabetes and hypercholesterolemia, are so common. So I usually do that regularly. And then sexually transmitted infectious screening. These should be done per the CDC recommendations. So if any symptoms are up, you should check. Anti-androgen is trying to combat the effects of testosterone, and usually we use spironolactone. This is commonly a diuretic that we use for high blood pressure, um, but at higher doses, it actually blocks the testosterone receptor and helps to reduce the production of testosterone. Some of the side effects can be polyuria, polydipsia, so peeing a lot, drinking a lot, um, uh, and having kind of lowish blood pressure and dizziness, and hyperkalemia, which is high potassium. Um, I usually start at a dose of like 50 milligrams twice a day. And we usually don't go any higher than 200 milligrams twice a day, although I rarely ever use those kind of levels. Um, and you would check a testosterone level to see if it's appropriately suppressed. Next slide. When should you expect the effects? Generally, breast development I see beginning, about 3 to 6 months after starting. Um, you know, at 2 to 3 years, you should generally see the most you're going to see with estrogen. Um, you'll see a redistribution of fat. A lot of fat in men is in the front, whereas in women it's more on the hips. And so you should see that in 3 to 6 months. And like I said, you should definitely see most of the effects by 2 to 3 years. Um, you'll definitely see decreased muscle mass. Uh, and so you should see that in 3 to 6, and then you should see the entirety of it by 2 to 3 years. The softer body hair, usually comes on at 6 to 12 months. Um, the decreased oiliness of skin is about 3 to 6 months. All of these are usually about 3 to 6 months. The decrease libido or sex drive and spontaneous erections, usually that starts around 1 to 3 months. Um, and generally, it should be you'll see what's going to happen is going to happen by 3 to 6 months. And then testicular atrophy generally, comes on in 3 to 6 months, with the maximum effect happening in about 2 3 years. Side effects, you can get nausea. Um, so you want to consider reducing the dose or changing the way the estrogen is given. If that happens, you can get migraines and headaches. So you want to make sure you do an MRI to check to see if there's a pituitary adenoma. The pituitary is a gland in the brain. And then you can consider using the shots or the patch to get more consistent levels. Um, uh, Sometimes the headache is from the fluctuating estrogen that you can get with the pills, um, and increased risk uh, of stroke in women using oral contraceptives. It's hard to say whether or not this is because of the bioidentical estradiol, or this comes on because of the bioidentical, because it does happen in the non bio estrogen. Generally, you want to sort of use guidelines. UC San Francisco has some clear guidelines on when you should or should not use these hormones based on stroke risk. And then if you get a clot, you want to make sure that the patient isn't smoking. I usually just harp on people who are on hormone replacement to stop smoking. That if we are friends, that's what happens. Um, um, we sometimes will switch formulation, like we'll switch the patch if a clot happens. And usually at that point, if a clot happens, I'll refer to hematology to work the patient up. It's extremely important, like even though we're delivering sort of medical care, to understand that patients don't show up by themselves, that they come with a whole host of baggage. And the Family Acceptance Project is this study that looks at the effects of families on LGBT young people, and the study shows just how big the risk of suicide is in patients who are rejected by their family. So, one of the things that physicians have to mediate in this population that they generally don't have to in other populations is to help the family come to terms with their LGBT family. When families are supportive, patients have better self-esteem, they get better support, and their overall health is better. And support can fight off depression, substance abuse, and suicide. So it's really important that we sort of like make sure that we address family as well when they come. Um, Research. I am happy to say that we are conducting research with Utopia. Um, we are doing a need study. It started in Washington. They were able to get some really good, fruitful data. We're now conducting the study in California, but it's open to other parts of the country as well to take it. You can go to. We don't have it up, but we we'll make sure we put the link um, to where you can get access to the survey. As I said before, Native Hawaiian and Pacific Islanders face a whole host of obstacles when it comes to the social determinants of health. They deal with racism, xenophobia, and classism in the workplace, in the schools, and this creates problems in trying to access education, healthcare, economic opportunities. So queer trans Pacific Islanders have to deal with all of that. But on top of that, they deal with homophobia, transphobia, which causes an increase in depression, drug use, unemployment due to ostracization. Providing gender affirming care helps make up a gap faced by our most vulnerable. Next. So, if you ever struggle, because I know people have complained to me about pronouns and not knowing, how to deal with this type of care as gender affirming care has become more noticeable. One of the things that Pacific people do really well is provide empathy. You know, and I like to think of empathy as the rope that helps you pull patients closer when they're swimming in an ocean of mistrust and alienation. Right? Okay, so that is the completion of our medical part of our talk. Thank you so much for joining us on this initial grand rounds. Um, Next slide. Um, I do want to sort of just make note to everyone who's joining us that we got done with our first one. And that Pacifica Grand Rounds is going to occur every Thursday or every Tuesday of the month at 5:30 p.m. U.S. Pacific time. We will make it known where you can access these talks should you not be able to make the live talks. During the live talks, you're able to ask questions in the chat. Um, so that might be a nugget for you to join us live. And we'll also provide our email address for the Happy Doctors so that if you have any suggestions regarding um, topics for future grand rounds, they'll be made available. Next slide. So hey, meet our team. Um, we are co-sponsoring this event just because the Healing Association of Pacific Islander Doctors, or the Happy Doctors, their charge is to improve care for all NHPI through education, outreach, and networking. They thought the Grand Round series is something very crucial to achieving that. Um, and then the Mapu Maia Clinic, I will let Tepa use this time to sort of tell us more about the Mapu Maya Clinic and advertise what you guys got going on.
Mhm. Thank you, Ray. That was a lot of information. And even I'm telling you, even as someone as myself who has lived as a trans woman for a very long time and has been on hormones, estrogen, for a long time, it was still interesting to read the slides and listen to how you talked about it because there's so much that we don't know even when we access these resources because we just go in with the goal that we have in mind and we don't really understand what does progesterone do to me and like all
Yeah,
of these things. So thank you for sharing that. As far as Mapu Maya, I hope that the introduction I gave earlier is sufficient. But I want to say that you can visit us at utopiawa.org anytime. You can also contact us at Mapu at utopiawa.org. That is the email, or you can simply call us at 206-774-9746. That's 206-774-9746. And then we did have a question, Dr. Samuel, that was in the chat that I wanted to raise. Um, is it dangerous to use erectile dysfunction medication such as Viagra while on HRT as a way to boost your libido?
Is it dangerous? No, but it should be monitored. We use some of those agents with women, with cis women, and so um, it's we don't use it often. We don't have a lot of research or experience with those types of agents and hormone therapy, but there really isn't a contraindication at this point. But it should be done with a doctor. Don't please don't be just taking pills without consulting your doctor when you're on these types of medications. Um, but right now I don't think there's a lot of people opposing it, but there isn't a lot of information that speaks to it as well. Um, oh, and then Pacifica by Design. Um, Naki, want to join us, or
I
maybe
guess.
we can't? Yeah. Um, just so you guys know, Pacifica by Design has so graciously offered
Wow.
to
Just
record
call
us.
me out.
Because you're so beautiful. Um,
Arts. Go ahead. I
yeah.
didn't mean to interrupt you.
No, we did want to make sure that people had access to these talks. Um, and Pacifica by Design, being the media giant that they are, um, is going to make it easier for us to access these talks. But they've also graciously uh, helped jumped in to help us record the talks as well. And so, um, was there what?
Yeah,
How did they?
I
Yeah,
think you covered everything.
yeah.
You can find Pacifica Grand Rounds on our YouTube page, and we're going to eventually down the road create a YouTube page, um, so that you can just find the recordings there. You can also find us on Mapu Maia's social media, Facebook, soon, and Happy Doctors. Will be airing live. Give us a minute. We're doing we're doing it little by little. We're catching up, but it's exciting talks that you both are sharing. Great information that needs to be spoken and talked about. So thank you both for sharing your thoughts. And this fire was amazing. Covered a lot of information. So I appreciate being a part of this. So thank you. I'm gonna head back and don't ever.
Next slide.
I do want to say, though, I think there's a lot more that you and I can talk about, but I think I was very conscious of that we have about 30 minutes. And I think the important thing for me was having people hear from a provider, you, on a lot of things that they might have questions on. But just one announcement, if you are tuning in, if you are watching this and you are in the state of Washington, please come out and join us tomorrow from 11 a.m. to 3 p.m. We will be hosting an open house ceremony in front of our new Mapumaya clinic, and followed by just hours of community celebration. We will be grilling, we will be singing, and it's really going to be a moment of celebration for us, because I'm telling you, this is our first time building a clinic and it was not easy. It's a lot of work. But yeah, please join us in celebration tomorrow if you can.
Yeah. So this is the Grand Round series. We're going to get a speakers list. We'll have topics up. So at the Mapu Maia Facebook page and the Happy Doctors Facebook page, we'll have these. We'll have the larger schedule for the Pacifica Grand Round, so people can know which talks are happening when. Um, for those who need continuing medical education credits, we're currently working with my hospital, City of Hope, to help provide those. So, you get something more out of it than just knowledge. Um, and then we'll be marketing it out on our social media networks. And then one of the things that we're going to need to make this better is to fill out our evaluation forms when those become ready. Next slide. So as I said before, we plan to do one every month on the third Tuesday of every each of the months. We just did May, so um, we'll have that schedule out. The third Thursday of November is usually Thanksgiving, so refer to the schedule. Another way for you to be made aware of when it's happening is to join our email list so that we can send an Outlook invitation so you'll know when the talks are changing. Next slide. That's it. That's it. So that's our email, happydoctors@gmail.com. And then we're also on Facebook. We have a page. It's brand new. It's still hot because we just opened it this morning. Um, and anything else, Tepa, you wanted to add before we sign off?
No, I look forward to the next talk.
Yay! All right. Thanks, everybody.